Hello. In this video, we're going to talk about intrapartum care of patients living with HIV. First, it's important to note that testing during labor is the last opportunity before childbirth to identify pregnant people with HIV. And for this reason, a person with unknown HIV status at labor should be recommended to have rapid HIV testing. Not only is this a recommendation, but in Illinois, it's actually a law. Briefly, regarding HIV testing recommendations, ACOG recommends routine, universal, no specific consents opt-out testing for all pregnant people. And they additionally recommend repeat third trimester testing if the pregnant person has risk factors, is in an area of high prevalence, or has previously declined testing. In Illinois, the Perinatal HIV Prevention Act, which has been in place since 2006, it requires hospitals to counsel about and provide testing for pregnant people presenting to labor and delivery without prior testing. And as of 2018, we initiated mandatory third trimester repeat HIV tests with testing for the neonate if this testing is missed or declined. This testing process is a key element of intrapartum care for people living with HIV, as it provides a last opportunity to initiate interventions that may prevent transmission. Regarding transmission, the next thing we'll speak about is the use of zidovudine during an intrapartum or antepartum setting. The PACTG AIDS Clinical Trials Group, PACTG 076 study demonstrated that the use of zidovudine compared to placebo led to a 66% reduction in risk for transmission, and efficacy was observed in all study groups. So for this reason, the standard is to use zidovudine at 2 mg per kg of body weight over 1 hour as a loading dose, followed by a continuous infusion of 1 mg per kg of body weight per hour until delivery of the infant. But what about zidovudine in the era of combination antiretroviral therapy? Guidelines would say that if a person is receiving combination antiretroviral regimens and her HIV RNA is less than 400 copies per ml near delivery, IV AZT is not required. And I'll show you these guidelines in just a second. Rationale for this comes from the French perinatal cohort, in which over 11,000 people who delivered between 1997 and 2010 were studied. Of these, 554 did not receive zidovudine, and they found that in people with a viral load less than 400, rates of transmission were 0% with zidovudine, 0.6% in the presence of IV zidovudine, if the viral load was between 400 and 999, and 7.5% if the viral load was over 1,000. They concluded that IV zidovudine may not be necessary, but it's important to note that this was retrospective and they did not control for duration of labor. Additionally, it was one cohort, and we continued to give neonates zidovudine for pre-exposure prophylaxis as well as postnatal prophylaxis as well. Here are the latest U.S. perinatal HIV guidelines. They note that in patients with a copy of less than 50 copies per milliliter, what we would consider undetectable, that IV zidovudine is not required. And between 50 and 1,000 copies, it's not required, but many experts would recommend it. Whereas over 1,000 copies per milliliter, IV zidovudine is recommended, and typically in these scenarios, it's being provided prior to performing a cesarean delivery, which I'll touch on in just a moment. However, despite these guidelines, our practice at Northwestern is to continue to use IV zidovudine for all parturients, even if their viral load is suppressed, because we believe strongly in the role of zidovudine as a pre-exposure prophylaxis regimen. You'll note that there are other aspects of the perinatal HIV guidelines that comment on mode of delivery, artificial rupture of membranes, induction of labor, and others, which I will comment on in a moment. I highly recommend reviewing this guideline if there are particular questions about intrapartum management. Next, regarding route of delivery. Cesarean delivery is recommended prior to labor onset, typically at 38 weeks, for people with HIV RNA levels that are over 1,000, for people with unknown HIV, and for people with unknown HIV RNA levels. So these are typically for people who present with a new diagnosis of HIV, who have a viral load that is not yet back, and who have an obstetric indication to proceed with delivery prior to receiving the viral load. The benefits of cesarean are unclear, though, after rupture of membranes or onset of labor. And so for this reason, it's important to base the decision on clinical factors, such as what has occurred so far in the labor process and how remote she is from delivery, as well as the viral load. Regarding labor considerations, obstetric procedures that increase the risk of fetal exposure to maternal blood may have been implicated or are potentially implicated in increasing the risk of perinatal transmission in some, but not all studies. However, many of the studies about invasive procedures in the antenatal setting, such as amniocentesis, were really before the era of viral load monitoring. And now with the use of viral load monitoring, some recommendations have changed when we know that individuals have a suppressed viral load. So we generally always avoid fetal scalp electrodes because of the possibility of exposure of maternal blood. But intrauterine pressure catheters and operative vaginal deliveries may be considered with caution only when there's a very clear obstetric indication in the setting of suppressed viral load. In patients who do not have a suppressed viral load, these should generally be avoided. Similarly, we avoid artificial rupture of membranes in the setting of viremia, but this may be an acceptable obstetric consideration in the context of a suppressed viral load on antiretroviral therapy when indicated for obstetric reasons. We generally would avoid a very early ARUM, and these are important considerations. And there are many important considerations to take into consideration when thinking about whether to perform these procedures, such as viral load and adherence. We also want to expedite labor once rupture of membrane has occurred, because we know that the duration of labor is associated with increased likelihood of transmission. And then finally, it's important to note that in people receiving protease inhibitors or efavirenz, that methotrexate should not be used unless there are no alternative treatments because of the potential exaggerated vasoconstrictive response. If there are no alternative medications available and the need for methotrexate outweighs the potential risks, it can be used in as low a dose as possible for as short of duration as possible. And then finally, there's a few key important labor considerations that are important for all pregnant people living with HIV. These include considering confidentiality. Although laboring patients may have guests with them, these individuals may not know that the pregnant person has HIV. And so it's important to remember that things like the zidovudine that are hanging or the alterations in labor management needs to be discussed with the utmost confidentiality around guests. In addition, we still encourage maternal-infant bonding despite the need for medications and early bath, and recommend that these be done on maternal chest if at all possible, and certainly in the labor and delivery room. And then finally, it's important to ensure good communication between the obstetrician and the pediatricians in order to make sure that the neonate gets their post-exposure prophylaxis and any tests such as an early viral load if needed. We'll be happy to answer any questions in our live session.